Good afternoon, everybody. I'm happy to welcome to this session this afternoon in the European Telemedicine Conference. Welcome to this room, which is seemingly a little bit steep, and the future can sometimes be perceived as such. But I think we will have presentations here now that will justify it, and will make it possible to climb what is there. I would like to welcome our first participant, our first presenter, which is Wencke van der Meijden from KPMG in Norway, the future health continuum of dementia.
Thank you. Are you able to hear me already? Yeah? Okay, great. Can't hear any difference. Thank you for, it feels very impressive like this. Thank you all for coming to our session. My name is Wencke van der Meijden. I am responsible for the healthcare sector within KPMG here in Norway. Originally I'm from the Netherlands, where I've worked the last 13 years as a consultant within healthcare, with hospitals, elderly care, mental health care, and the government, all in order to improve the provision of healthcare. And a year ago I moved to Norway to become responsible for the healthcare sector here and to build our healthcare deliveries here as well. At this EHiN conference we hear a lot and we see a lot and we feel innovation around us. And that's not only very inspiring, but it's also very necessary to be able to cope with all the challenges that we will have in healthcare. Today we will present to you a study that actually investigated all the innovations that are developed, are being developed, or already there when it comes to the continuum of dementia care. And what we mean with the continuum of dementia care, it's from diagnosis until the last phase. It's not without a reason that we chose dementia care to do a study about it, because it's on a lot of the agendas of national policymakers, on regional policymakers, and on local policymakers, because it is a disease that will get a lot more attention and a lot more of the budget the coming years. We all know the challenges of our double aging population, so more people get older, but less people are also born. So we'll in total have an older population. Instead of 1 out of 5, 1 out of 4 people will be above 65 in a few years. And that means that in our population we will have a lot more people with at least one or maybe more chronic diseases. And one of those chronic diseases with a progressive character is dementia care. And it is a disease that needs a lot of care, that needs intense care, and therefore we face a major challenge as society to cope with that increased demand. And we know that more funding, more workers, and even working even more efficient in healthcare won't solve that challenge. We need innovation to take care of the future. So innovation in medicine, innovation in treatment, and innovation in other services that enable us to keep delivering high quality of care and a high quality of life, which is very important in this patient group. Today we are very proud to show you the first results of a study that we have done on the innovations in this area. And as a preparation, I actually looked at the news, and what you can see there is that dementia is a trending topic. It becomes a leading cause of death, for example, in a lot of Western countries. But there's also a lot written about innovations and new technologies, new ways of working in this area. Let's take a look at the facts. With an aging population, will we need a different type of care? Well, we see that we would know that 1 out of 5 people will develop dementia during their life. And that means worldwide that over 74 million people will develop dementia. And only in Norway, that is already 80,000 people with dementia care. And we also know that that amount will double in the coming decades. Healthcare costs have always been a challenge, but now it's even more a challenge. And if we don't tackle it, we also know that half of our income we will spend on healthcare in 2014. And dementia care will actually take a major part of that budget. But it's not only about the cost, because we also know that dementia has a huge impact on the people that get it, but also on their families and the people around them. People around them, so the informal caregivers, the family and the friends, actually experience overpressure. So a lot of them is asked to take care of their loved ones. So if we look at the aging population, the question rises, will we be able to keep that high quality of care in the future? And we think that the innovation should be found in new ways of delivering healthcare. And it is already been said a lot by different speakers, but the future will be digital. The future has to do a lot with innovation. And we think that innovation and the startup scene can actually create an answer in delivering a high quality of care and a high quality of life. In the next 20 minutes, I think I have about 20 minutes, I will give you a very brief overview of our study and our main findings when it comes to what type of innovations do we see and what do we expect of the effects that the innovation has. And the goal of this study is to give national but also local policymakers, maybe people from the institutes, an overview of what's going on in the sector, what are the new possibilities. So they are not only able to maybe make their strategies around them, but also maybe enable them to buy innovation and implement them, and already adjust their way of working and maybe even their business model into what we see happening in the new way of delivering healthcare. And in the study, we looked at 4 different phases of the disease. First of all, of course, the diagnosis, then adjusting your life to living with dementia. The third phase, intensified care at home. And the fourth phase, living in an elderly care home and maintaining the quality of life as long as possible. In this slide, I actually gave you our main conclusions of what we expect of innovation. So the effects of innovation in, for example, 2025, through a bird's eye view, will be that patients will get diagnosed earlier. And that's a good thing, because the sooner you get the diagnosis, the sooner you're able to adapt to the disease, and that increases the time of life in good health. We also see that, in general, the progressiveness of the disease reduces by all the innovation, which means that the function of the brain is maintained in a good state for a longer period by, for example, better medication or personalized healthcare plans. Third, we expect that innovation, or we predict that innovation makes it able for people to live longer at home. So the demand for elderly homes will decrease by many different ways that I will go a little bit deeper into later on, by, for example, supporting the informal caregivers and make it more secure for people to live at home. And the fourth, very important one, is that the quality of life is maintained longer by all the innovations in this area. For example, by technology that ensures patient safety, but also by technology that actually contributes to the joy of life for these patients. What we've done is that we've made a scan for all these areas to see what type of startups and what type of innovations do we see around the world and in Norway. Our rule was that the innovation had to be not more than 5 years old, because otherwise you can hardly call it innovation. And it doesn't have to be developed already, but it can also be in a testing phase. We actually searched and did a lot of interviews through the field and with a lot of experts. What I will do is that per each phase, I will go a little bit deeper into what type of innovations do we see. And I will show you some examples, both international and from Norway. For example, the first phase, the diagnostic phase, is, we see here the different categories of innovation. And in the big box, you see a lot of logos of, on the left side, international companies, and on the right side, Norwegian initiatives, companies and startups that contribute in this area. For the first phase, diagnosis, we know that in Norway only, already 9,000 people are diagnosed with dementia each year. Only 40% of those people are diagnosed at the first sign of, as the first symptoms. Unfortunately, the average time of having first symptoms and a diagnosis of dementia is on an average 14 months, which makes it very hard or more difficult for those patients who got diagnosed very late to actually be a director of your own care plan, to actually express what you would like, how you would see yourself, and what type of care you think would be important for your situation. We forecast that new technologies create the ability to diagnose dementia and Alzheimer's 3 to 6 years before first symptoms arise. And that's a major win in both treatment and quality of life, or the functions that you can have, the amount of years that you live in health. And we see innovations in 3 different categories. The first one is enhanced knowledge sharing. We see big platforms, both national and also a lot here in Norway, that are investing in sharing knowledge about the latest research on first symptoms, to connect healthcare providers and to connect experts with each other to exchange useful information. Other categories are, for example, early recognition of the diseases. We see very interesting developments on computer-based virtual cognitive tests. They're all in a test phase, so they're not on the market yet. But it helps physicians to predict the occurrence of dementia and Alzheimer's before first symptoms actually occur. And the last one, improved diagnosis. We see technologies that are able to diagnose dementia way before the first symptoms by doing eye movement tests. This is a very new technology, also still in a test phase, but it's very promising. And although you may doubt if you want to know that you will get dementia in 3 to 6 years, it has such a major impact on keeping your brain in a good condition for much longer that it's very important for all of us to diagnose it that early. If you look at the Norwegian examples, they're not really high-tech. They're nice platforms of Fagnet Demens and Kunnskap om Demens and the National Vereniging for Alderomsorg, Folkehelse, and the Demens Covered. So that it's not all digital, but we'll see a lot more Norwegian digital examples in the next phases. Progressiveness of the disease that will reduce, that can be done by, for example, software applications that are able to manage your care plan. If you are diagnosed early, it enables you to express what you think is important. Then we see a lot of technologies or a lot of platforms and software support systems, for example, by IBM is developing a very important one, that enable you to tell you what you think is important and to translate that into a care plan that not only manage your needs but also monitors outcomes. And of course, better treatment and medication for the disease. And with medication, we of course see developments in drugs with pharmaceutical companies, but we also see, for example, wearable devices that monitor brain activity and are actually able to trigger the brain in order to keep it more healthy for a longer period. We see serious gaming that keeps the patient fit and more activated in their disease process. And a very promising development is open data sources that enable patient data, of course on a very secured and anonymized way, being accessible for professors and scientists that create much larger clinical trials and therefore have a much higher value in developing new or seeing new trends and developing new ways of medication. Phase 3. So you are having the diagnosis and you're adapting yourself to living with dementia. But at some point, care at home intensified strongly. And we see that because of innovations, people are able to stay much longer at home than we are used to now. And that is because we see innovation that relieves the informal and the formal caregiver in delivering healthcare at home. You can think about technologies that actually enable you to connect with other services than the services that we're used to now. 24/7 professional caregivers on the private market, but also maybe buddies or volunteers that you can connect with. We see apps that help informal caregivers to connect with their patient, with their loved ones, but are also able to connect with healthcare professionals, and they can share the responsibility, and they can share what is important for the patient and how they organize the care around the patient that is still living at home. And of course we see technologies that have everything to do with robotics, electronic pets, for example Blue Ocean robotics that is also here on the stand is an example of new techniques of communicating on a distance with your loved one, or having pets at home that stimulate people to keep interacting and don't feel them at home. One of the examples of the apps in this area is Yoda Care. And maybe, Kristen, you would like to come up and tell just a little bit about Yoda Care.
Sure. Oh, bright lights. I'm Crystal. I have a mom with Alzheimer's, and I did take care of her with medication and giving food and taking care of her. But at a point, I couldn't anymore because there was too much work, and I had my job and I have kids in my own house. And my mom would call me at night. She would call me and said, "You know what? We need to go to the drugstore again because I don't have any sleeping pills." And I was 10:30 at night. And I would think that the home care personnel had been there, but she told me they hadn't. So it's really late, and I need to call the home care people. And they didn't know because they were out driving in a car, and they said, "I'll call you back in 10 minutes." And they did call me back in 10 minutes after talking to other healthcare personnel that hadn't been at my mom's house. So she could tell me that, yes, they'd been there today, and they put the sleeping pill on her nightstand. So then I can call back to my mom, tell her, "Yes, you had the pills, you just took them already." And I thought, I need a better way to handle this. I need a way to know what happened at my mom's house before she calls. So that's why I made Yoda Care. It's just a platform for communication between me as a family member and the healthcare personnel. And it looks very much like Facebook, only that it's really close. It's for me as a family member and for healthcare personnel. And we can share stories, pictures, calendars, messages to and forth. I can ask questions and I can answer. And we were funded by Innovation Norway in January this year. And now we are in pilots in 9 municipalities in Norway. Is
Thank
that
you.
okay?
Yeah.
Yeah,
Thank
sure.
you.
Thank you.
Thank you for sharing your experience and also your innovation with us. That was actually what was most inspiring about doing this study. That because the disease of dementia is is so big, it's everywhere. We see that there's so many people with a loved one developing smart and new things in organizing the way, reorganizing the way of care and organizing it in a better way so that they are able to have their loved ones stay home much longer than we're used to. So it was very inspiring. We also see an improvement in knowledge and understanding of the disease by virtual glasses that simulate for health personnel how it is to have dementia, to understand how it is, and other apps that enable you to ask the right questions. We see technology support for day-to-day structuring as big visual agendas and iPads that also not only show but also vocally support what type of time of the day it is in order to have someone, to help someone with a structure in their life. And we see, of course, safety and well-being of the patient is increased by all the sensors and the GPS tracking. The study will be available soon, so then you can read all the interesting innovations and all the interesting effects that we see. Phase 4, and that's the final phase, it's the nursing homes. Quality of life is maintained much longer because we see a lot of apps and technologies that increase the joy and happiness for patients. For example, Seisoensfilm is a Norwegian initiative to create movies of experience that people enjoy. Or Memoria, which creates an online memory for people to memorize family members, but also to store pictures from their youth. And hence safety in nursing homes, it's a very well known, it's something that Norway is very active on. Facilitation of professional caregivers, to have more platforms to support also their care planning, and improved communication methods with patients to keep being able to communicate with patients although they lose their ability to remember or to express what they want. Final slide, because I think I have still 1 minute. It was very inspiring to do the study, and if you want to know all the details about what's out there, and the effects of the innovation, I would suggest that you leave your card here, and I can send you the study in a few weeks, because then we will finish it. But it's very important also for healthcare providers to think a bit about what are the consequences of all these innovations. Because if a patient will be much more knowledgeable and knows much more about the disease and is much more early aware of what he wants in this disease, the model is much more about shared decision making between the patient, its family, and the care organization. Healthcare providers will much more have the role of guiding the patient through its disease process and will have to plan care in much earlier stages. You will see blended care models between the public care, but also private and volunteers and the family. The distinction between care and well-being will fade out because it's just as important. And healthcare providers will need to overcome their traditional way of thinking about the delivery of healthcare. They need to be open for new influences. An integral approach to using technology. They have to be open for technology. That means that they have to be able to buy it. They have to be able to implement it. But they also have to be able to educate their people to work with it. And of course, if you really think ahead, it needs strategic workforce management, because we will see a lot more people who will stay at home, will need hjemmetjenester, help at home, and we'll see a lot less people in elderly care homes, but of course the people who will be there will be much more heavy. So you will need much more higher educated people there. So the way that we see healthcare is organized now might change, but with innovation, we all think it will change for the better, and we really hope that we can all get the benefits out of this. Please leave your email address after this session, and we can send you the study if you're interested in reading a bit more or talking a bit more about it.
Thank you very much, Wencke. I think I would like to make use of the chance to be the first one.
Thank you.
Thank you very much.
Yes, thank you.
And as a thanks for your participation, you have this. We actually have time for one question or two if somebody has something for Wencke right now. Is there? Please not only raise your hand, but also say something. The light is shining and it's difficult to see. If not, maybe you will be here also afterwards a little bit. Oh, here's the question.
And how you work. Thank you. I should maybe also introduce myself. I'm Anne Moen. I'm a professor at the University of Oslo. My question relates to the healthcare providers and how your solutions work. How do you work with the health providers to establish a reasonable path for change? Not just say that they have to change, but what is your thoughts on that direction, and particularly how do you work with them in that regard?
Yes. Yeah. Well, we of course work a lot with healthcare providers, and a lot of the questions are actually about how are we able to deliver better healthcare and healthcare for the future. And we see that there are actually 3 phases that we identify, and that would be a whole new presentation. But we see that we help organizations build a culture that is open for change. We help procurement offices to be able to procure innovation, because it's really difficult to procure innovation, while plans for next year are already made, budget is given out. So we help to develop a more innovative way of procuring. And we help organizations with a lot of lessons that we've learned in implementing new ways of working. Because once you have a culture and you've bought it, a lot of the implementations still fail. And there are several lessons, and if you give me your card, I can send you a report on that as well, on how to actually make digital health work, because it's not always easy.
Thank you very much, Wencke. Now for Gunnar Hartvigsen from the University of Tromsø, traveling from a little bit further north in Norway, not only a little bit, it takes a while to get there. We will hear about motivation in mHealth, eHealth and telemedicine. The floor is yours, Gunnar.
Thank you. So I'm also at the Norwegian Center for eHealth Research. And the starting point for this presentation is actually 2 observations. And I guess quite many of you have also made these observations. The first observation is that there is now a fundamental shift in the interaction between the patients and doctor, and this is an international trend. So it's this is the new digital medicine, where patients are using apps and devices to work together with their providers to live healthier lives and also reduce the frequency of visits to the hospitals and to the doctors. Also, they have their personal devices carry with them or at home that are keeping them healthy. And the technology also allows the patients to also record everything what they do when it comes to their health, and also to keep track of their progress over time and potentially also address issues before they become too serious. One of the companies that I have looked into that seems to have understood this quite very well is Twine Health, which was started from an MIT graduate. And I will show you a video how they organize this interaction.
You know, I really like to lower my blood pressure.
Great, let's make a plan.
Hi, Ellie.
Hey, Grandpa, can we finish my bag tonight?
No, I'm sorry, Ellie. I have to see my doctor this afternoon. So I'm gonna have to stay late at work. What if we finish your bike up over the weekend?
Okay.
Okay, so this is how we want the cooperation to be, a close cooperation, and also they said on their webpage, and there was also some papers that they published, that one of the studies they managed to get 100% of the patients involved to reduce their blood pressure. And there are also many other things that are happening. We have the Internet of Everything, which is happening now with increased speed. Everything is going to be on the internet, which gives us a lot of new opportunities. Of course, we have what is happening also in the possibility to integrate the data. For instance, with this the health kit from Apple, where you have so the thing is that then all your health data can be shared between different apps and different systems, and that is the I would say the revolution with this. The second observation is based on the work that we have been doing over the years with people with chronic diseases, diabetes, and it is that it's all about motivation for this patient in order to keep them on the treatment regime year by year. So and it is very, very difficult to do this. And we have been working with both type 1 and type 2 diabetes, all ages, and we have a big team with with doctors, endocrinologists, GPs, nurses, and people with a technology background. Because the challenge is, of course, that you cannot take some days off from your problem. You have to stay on the treatment regime, and as one of the doctors said, that the people they know exactly what they should do. They know the consequences of not taking care of their following the treatment regime, but still they don't do it. So we have a big challenge here, and of course for people with diabetes, it's a question of balancing physical activity, nutrition, and medication, which is basically insulin. And if we look at how we are doing, the patient groups in Norway, for instance, it's only 35% in Norway they managed to achieve the International Diabetes Federation's goal of long-term blood glucose, HbA1c, and it's only 6% that reach all treatment. So this is obviously here a room for improvement, and that's where we are. And one of the things we do, we try to update the patient and keep them updated how they are doing, so that they can make the correct decisions with different self-management tools. And over the years, we have developed different versions of what is called the Diabetes Diary, the Diabetes Dagboka, which is available both on an Android platform and an iOS platform. You can download it from Google Play and App Store, and we also have a smartphone version, which also is integrated, running on a Pebble. I will like you to meet one of the users of the diary, and you can see how he's using it.
Avoiding lengthy journeys and frequent consultations. Living on the island of Vannøya, 100 kilometers north of Tromsø by road and ferry, Dag Solberg is an example of someone who's benefiting from trialing the app.
Nei, angående, jeg brukte jo hefter å notere i da, alle målinger og hva jeg setter av sprøyte og hva jeg hadde spist. Men etter det her så har jeg jo helt sluttet med det da. Nå går det bare på telefon alt. Og det synes jeg er mye bedre da, for telefonen har jeg jo med meg bestandig. Så det. Og måleapparatet, det har jeg jo i lommen, uansett hvor jeg er. Så, men jeg synes jo også at jeg har litt mer kontroll da, når jeg har det på telefon. Jeg er veldig fornøyd med å bruke den, og synes den er veldig enkel og grei for å få oversikt på en måte. Ja, og litt kontroll da, selvfølgelig.
Etterpå det så har han kjenner når det begynner å krype under 5-4, så da merker han det på kroppen at nå er det lavt, og nå må jeg måle og spise høyt. Så nå er det mye bedre.
Okay, also this is, I will also like you to meet one of the endocrinologists we are working with.
Often patients say that my blood sugar varies a lot and I don't really understand it at all. So what's happening? How should I do this? Having those measurements, sharing it, looking at the same data simultaneously and discussing the data makes it so much easier. The app is a very good tool for the pedagogics of teaching carbohydrate content counting in order to do the adjustments optimally.
So we have been working with different kind of solutions. I will not come into this, but if you are, I'm really happy to provide more information about what we are doing. But I will say something about one of the, because we are trying out different kind of technology to actually motivate the users to be optimally regulated. So what this is, I just very quickly will show you some example of what the users record. This is the main screen. From this, they can, for instance, record how they are doing with the carbohydrates, and it's also they can, if they need more information, the matvaretabell, the food table of Norway is included, so that they can look up how many carbohydrate it is. Of course, insulin is recorded, physical activity, both manually but also by runkeeper to runkeeper, which is integrated blood glucose in different way, both through this manual finger steps, but we also have more users now that are using CGM. And they can have the blood glucose presented in different ways. They can study on daily basis, weekly, monthly. They can set the interval themselves. And there are search function, for instance, if you have something that you haven't had for a while. Well, what did you do last time? How much insulin did you took, and what was the result afterwards? So you can go back and study. And there are you can look for similar situation, study trends over time. For instance, you are unsure what was the consequences last time you had this amount of bread, and then you can look up what in your database what has been the historical data that is stored. You can study trends both daily and weekly. The daily period is the average of the last 14 days. The weekly periodicity is the 6 weeks. But this is not enough. So we have in order to also to follow up more closely the patients, the user, and motivate them. We have other functions. You can now also you have through the smartwatch you can we have voice input with support Norwegian, Swedish, Finnish, and Danish, and even English, as you see. And this is one of the functions that have been developed. That is technology that we have played with. What you see here is a girl with type 1 diabetes. She is and her father is sitting in their home, and you see there is a green lamp. That means that her blood glucose level is okay within the recommended range. And then after she measured, she is a bit too low here. So therefore, the lamp immediately changed color, and so the father takes up the phone and contact her in order to see what if everything is okay. So this is technology that are off the shelf, so that we have modified, taken over the control of the remote control of this color bulb, and also made some hardware for this. We have tried to send the signals through the RDS FM radio, so that they can have the measurements on the radio display and also have it on the radio. So we play with technology, and we have also worked more and more with kids. One of the things that were presented yesterday was, for instance, this Furby toy that is a modified version of the traditional Furby with a lot of more technology inside. Here is a small video that shows you how it works.
Okay, it is time to check your blood glucose. Your glucose was 11.2, which is a little high. Ask your parents if you should take some insulin. Good, your previous glucose 1 hour ago was 8. So it seems like it is increasing.
The only problem is that we haven't managed to use Norwegian for this communication. And we also look into, we are going to work with other technology like now is the next. We are going to look into if we can replace the Furby with the new robots that are coming, which we think can be a very good partner for the kids. And can use them to motivate the kids. We also have are cooperating with this. We are our Night Scout. We are using the application and have also made our own communication unit in order to get the data from the continuous glucose monitors to made it available for those who want it. For instance, so this was started as with the parents with type 1 diabetes in California. They wanted to. They didn't accept that there was only the kids that had access to the blood glucose level from the continuous glucose meters. So since the companies didn't want to help them, they had to reverse engineer the process, development process here. They managed to get the format of the data that was communicated from the glucose meter to the handset, and then they built some hardware to send it to the phone and then to a cloud-based application, so now they could access it everywhere. And we use this, and Erik Årson is the leader of this the diabetes team. He has type 1 diabetes, and earlier this year I was sitting at my desk at the research center, and the lamp that you saw is actually very close to me, and I saw that it was red, and on the display you see here it was his blood glucose level was going below 3, and that was not good. So I had to contact him, and then he said, I'm sitting here in Stockholm and I just ordered a plate of pasta, so I'm good. But thank you for calling. So this is how this could operate. And I said I was in Tromsø, and that is 1,500 kilometers away. So this is what they have done. This is the company secret, the communication, but but they didn't accept it, so they developed their own devices, and the box that you see here with the green box is the one that we have developed in Tromsø. That is actually what also Erik is using in order to distribute his blood glucose level to this cloud-based application. We also working with social media applications in order both to share experience, but also to share knowledge, and also to share the glucose values among other people with diabetes. And we are looking into different games so you can to motivate, for instance, children to use the diary or to learn more about their health problem by playing games. What is the consequences of having a high blood glucose value? How can it be reduced? We have another student that are working with this is actually like an aquarium where all the fish they have diabetes, and the goal is to keep them healthy so that they can be sold to others, and we are making a lot of different functionality around this for small children to learn about their health problems. And we also have a version where you can share the data with your doctors from your app. And the doctor can zoom in and do different study different parameters here. And we have had students working with motivational mechanisms. Some of my students, for instance, suggested that actually the whole phone should change color according to the background according to how you were doing when you were using the app, or the app itself could change the color according to how you were doing, and use more different kind of social media reward systems, and also other interesting thing like of course setting goal, but mood, also try to detect the mood of the user in order to apply different kind of reward mechanisms and motivational mechanisms for that person in the right moment. So we are working a lot with motivation here, and next is more big data analytics. We are also working with that. How can we take advantage of all the data that all the users are recording, and in order to improve the predictions for each of the users, and also to use them in games so that the avatars can have really realistic behavior. We have another project where we are looking into using the data for disease surveillance, where we try to, it's called the Edmond project. I have one PhD students here working on that, where we try to predict the spread of diseases by looking at the development of the blood glucose level at a much earlier point of view. Okay, this our project has been funded by quite many different sources, which we are very grateful for. And I think my time is out now, so if there are any questions, happy to answer them.
Thank you very much, Gunnar. Also, a thank you from the ETC conference for your participation. And were there anybody who had a question to Gunnar here before we say thank you to him completely? Not right now? That is good. Thank you very much. We have moved to the northern region. Now we are going to the Northern Territory of Australia. We have been through dementia and diabetes. Now we are also thinking about dementia. Diabetes. Please come up. We will welcome Isabel Skinner, and a little bit later, Darcy Ellis, who comes from the Charles Darwin University in the Northern Territory of Australia.
Thank you very much.
We are going to see some software here today.
Yes,
are we not?
Absolutely.
I'm looking really forward to that.
Okay.
The floor is yours.
Thank you very much. Now, I just check that my next works. It does. So it's wonderful to be here in Oslo. Oslo is a very, very long way away from Charles Darwin University in the Northern Territory of Australia. But we feel like we have come from one extreme environment to the next, and it's a great thing to be here. So Monday was World Diabetes Day, and on Monday, people who are interested in diabetes were celebrating the fact that 125 years ago, insulin was invented. It seems unbelievable that it was such a short period of time. This life-saving drug has helped millions of people with type 1 diabetes around the world. And diabetes occurs when the organ, the pancreas, stops working and producing insulin, or when the insulin that is produced can't be used by the body as it's meant to be. In 2015, type 2 diabetes was the fastest growing chronic illness in the world. The International Diabetes Federation estimated that 1 in 11 adults had diabetes. That is 415 million people globally, with half of those people actually undiagnosed. It is also estimated that 12% of the global health budget is spent on the care of people with diabetes. That's 415, it's extraordinary, $675 billion US. Despite this, 75% of the people who have diabetes live in low-income countries, and they have poor access to diabetes care. With so much money being spent, it's sort of hard to believe, why it would be so expensive, really, for this one condition. But it is important because too much sugar in the blood causes damage to the large blood vessels and the small blood vessels. Left untreated, the effects can be severe and tragic, causing a range of things, as we've seen: blindness, kidney failure, stroke, heart attacks, sexual health problems, and lower limb amputations. In 2012, the World Health Organization estimated that 2.2 million deaths were attributed to high blood sugar. But the real tragedy in that is that type 2 diabetes is actually preventable in many cases and can be managed using inexpensive actions such as what and how much we eat, how much we move, take the medications that we've been prescribed to reduce the blood pressure, and having regular screening for complications. These are not high-tech solutions to a very complex illness. These are things that can be done fairly easily. Sounds easy. Well, it's not easy. People develop diabetes over a lifetime. They often go undiagnosed for a long period of time with symptoms of fatigue. They've been on a diet many times, and they keep failing. One of the problems with that is that they think that they're now less able to manage their chronic illness because every time they've tried before, they've failed. And so they feel helpless and sometimes hopeless. And they feel trapped in a body with an expanding girth and the body that is failing them. There is hope, though. Evidence-based interventions that promote self-monitoring, understanding the actual risk factors, and setting achievable, small lifestyle goals one at a time and actually achieving them, we know that works. Our challenge has been to translate one of these effective programs, the Desmond Diabetes Program, which was actually developed in the United Kingdom, which has helped more than 200,000 people around the world over the last 15 years, in Australia, UK, Netherlands, and New Zealand. And we've been challenged with turning this into an app that can be used to assist people with limited access to a trained diabetes educator. Now in Norway, you probably have a lot of trained diabetes educators, but where we come from, in Darwin, in the Northern Territory of Australia, it's not so easy. We have a small population, 20 million people. Actually, I think it's 22 now. And most of those people live in the southeast corner of the country. But where we live, there's only 125,000 people and in the Northern Territory of Australia, and most of those people are living in Darwin, where all the health services are. However, there is a large number of people who don't live in Darwin and don't get access to services. We have, in the Northern Territory of Australia, extreme heat. And we have a lot of people who speak different languages. As you can see, these are the Aboriginal languages of Australia. We also have beautiful, pristine wilderness and many dangerous animals. But it's home to 72,000 Indigenous people, and they make up 30% of the Northern Territory's population. They live in remote and isolated towns and villages. And we have an incredibly high prevalence of diabetes in these towns and villages. Up to 30% of the adults in these communities have diabetes. Access to health services is limited, and people often rely on what is famous in Australia, the Royal Flying Doctor Service, in times of emergency. But type 2 diabetes rarely presents as an emergency. And many people have poorly controlled blood sugar levels, and consequently they suffer the long-term consequences, such as end-stage kidney disease, which is up to 30 times the average for Australia. However, mobile phone coverage in remote communities is ubiquitous, as it is in many, many developing countries in the world. And most people in Australia have access to a smartphone. This is a technology that has just expanded throughout the most remote parts of Australia. It's extraordinary. So we have developed an app, Emoji Fit Diabetes. It's an app designed to assist people with type 2 diabetes. It goes beyond the clinical measures of blood glucose monitoring and insulin titration, risk identification, to help people. It works with risk identification to help people identify diabetes distress. And we heard just before, it's an important part of diabetes care. It helps people persevere and build willpower as they build confidence in their abilities. It is an evidence-based approach to self-management. In the process of developing the app, we, the middle-aged health professionals, fell into the trap of making things incredibly complicated and very wordy. So after quite a long time in our development process, we engaged a communication designer and a software engineer, and we've got Darcy Ellis who's going to talk to us in a sec. The challenge for us was to translate a successful, evidence-based, face-to-face program that was delivered to groups, to one that would stand alone on a mobile phone and be understood by people with limited English and limited health literacy. Professor Tim Skinner, the designer of the Desmond Diabetes Program, had a range of resources that had been developed for the program, and these concepts needed to be included, such as categorizing risk, identifying complications that are most concerned to the person with diabetes, and developing scales to measure diabetes distress, well-being, confidence. There are also the issues of communicating clearly in a cross-cultural concept. So, from that, we found ourselves a young designer, a digital native, and our own Indigenous people will have access to something that is more useful for them. So this is just the stuff about the Desmond Diabetes Project. So let me hand over to Darcy Ellis. Thanks, Darcy.
Hi. So, as Isabel has mentioned already, in Australia, many of the people and communities most affected by diabetes also face a range of challenges accessing the vital medical and educational services needed to manage their diabetes. This is due in part to their remote location, as we've seen, but another key factor is low English literacy levels. So in order to meet the needs of our users, it was important not only to build an effective evidence-based app, but also to translate the information in this app to a format that was cross-culturally accessible, bearing in mind that there are more than 50 indigenous languages that are widely spoken, many of which have no written form. So, this was an initially daunting problem, but with some research, it became clear that there was a readily available, if not surprising solution: emojis. Emojis are now considered an official language, and the language is relatively new. Started in 1999 by a Japanese man named Shigetaka Kurita, and I've definitely pronounced that wrong. While working for the mobile company Docomo to send pictures back and forth without using much data. Today, there are more than 18,000 registered emojis used to express a vast range of meanings, from the simple and silly to the complex and nuanced. Our team saw emojis as a possible opportunity to solve the difficult problem of communicating a wide range of complex information to our users in a way that was flexible enough to accommodate both cultural differences and a limited level of English literacy. To do this, however, it was necessary for me to design a new vocabulary of medical and diabetes-specific emojis, ranging from appropriate dietary choices to physical exercise, disease, risk factors, related medical conditions, taking your medication, and more. This is a small sample of the selection of some of the emojis used for the initial demo, and there'll no doubt be more in future. Right. So, due to emoji's potential for assisting apps to more easily transfer between languages and scale more effectively, by smoothing intercultural communication issues, by supplementing written text, although we couldn't get rid of it entirely, we thought it would be worthwhile to highlight some of the design challenges we faced and how these were resolved to give you an insight into the process, because we think they're actually quite valuable and we might see them more in the future. So, our users are from a broad range of demographics, different ages, different races, different genders, and different body types. From the research we conducted, we found that our users did not respond as positively to depictions of people that were different from themselves. This presents an obvious problem. How could you possibly depict every demographic without having hundreds of different emojis for the same activity? And even if you did do this, how would you present these options for users to choose in an intuitive and user-friendly way without endless menus and customizations? The solution we came up with was to avoid depicting any physical or cultural identifying features of the human body where at all possible. For example, when designing emojis to depict physical activities and exercise, we chose to depict the accessories rather than the bodies performing them. Right, so in this case, gardening and cycling. But it is easy to imagine how these would apply to activities such as fishing, fishing rod, tennis racket, or football. So, while emojis are often thought of as being cute cartoons, and many of them are, it is important that they are first and foremost considered as communication tools, and as such need to be appropriate for the context in which they are deployed. In this case, many of the emojis are describing serious medical conditions and risk factors, so it is vital that they are not seen to trivialize either the users or the health conditions. So, for example, when depicting heart disease, the obvious love heart shape does not convey the serious nature of the condition. Our research pointed to the use of anatomical drawings being more emotionally effective in this case. Similarly, when communicating stroke and kidney disease, depicting the actual brain and the kidneys we also found to be the most effective amongst the trial users. This is not to say that all medical conditions should be depicted in a graphic way. as this can cause high levels of distress and anxiety if done wrong. For example, when I first designed the emoji to depict the loss of vision caused by damage to blood vessels at the back of the eye, using an anatomical organ of the eye, I did it, and it didn't go down with the trial users very well at all. Too scary, apparently, which is understandable, really. This underlies the vital importance of consultation, user feedback, and group testing. So I went back to the drawing board and designed a new emoji in a more approachable way, showing the use of an ophthalmoscope, which is used to test blood vessel damage in the eye, which is what a doctor would use, rather than the actual blood vessels themselves. Using emojis in the context of medicine can also present a range of unique design problems. Sometimes it is not possible, for reasons of decency, culture, or religion, to depict the medical conditions directly at all. For example, sexual health. Neither are depictions of the organs affected or the physical activities involved were appropriate. However, both women and men suffer from complications due to small blood vessel disease associated with diabetes. Women have difficulty with arousal, and men experience problems with erections. However, in this case, these issues were overcome using older cultural tropes and symbolic language. For general sexual health, I provided a generic image based on a road sign for no entry and a traditional love heart. This was well received by the trial group, but it was suggested a separate emoji was required for erectile dysfunction specifically. To do this, I modified the universal symbol for male. So far, both have been well received and easily understood in the Australian context. However, the risk with more abstract symbology like these two is that they may not be well understood globally. Again, further testing will be needed to understand the extent of this phenomenon. Finally, depictions of emotions and moods. This is probably the easiest application of emojis and can be leveraged to depict complex conditions such as depression, but can also be used to gauge user feedback and provide quantifiable and valuable in-app communications communication tools such as a confidence scale for the user's 4-week plan. The challenge of creating a universal language has in part been overcome by emojis, but like all languages, it is evolving, and each group has their own dialects. For example, Apple, Google, Twitter, Facebook, and now EmojiFit. Some are more successful than others, but all of them are only useful if they connect directly and intuitively with the user. To achieve this, clever design is necessary, but consultation and collaboration are vital. We've finished the demo and are now testing more broadly with users. We hope to launch the app on the Apple iTunes Store early in the year. To try and keep up with our progress, please follow us on the EmojiFit Diabetes Facebook page. Thank you. And there should be a video of someone, using the app. Right, and we can take any questions while it plays in the background, or if you'd like, we can watch it a bit more intently.
Any questions? I have a microphone if you want, please.
Thank you very much.
There's still a chance for a closing question. Keen for the last word? I'll say thank you very much.
Oh.
Great to hear. Great to see in the end here also.
Yeah.
Good luck.
Thank you.
Further. I'll take on behalf of the conference to you both. And have a good trip home.
Yeah, a long one. Thank you.
And to everybody here, thank you very much for attending this session. The conference is not quite over yet, though we are reaching the end. We are closing in on it. There will be some happenings in the larger social zone now shortly. So please stay put. Thank you.